Hello, everyone. We'll give everyone a couple, or not a couple, we'll give everybody a full minute to join. So we'll start right at 1:01. Okay, it's officially 1:01, so let's get started in the interest of time. Hello, everyone. My name is Brianna Montgomery, and I would like to welcome you to the Autism Intervention Research Network on Physical Health, the AIRP, September 2023 webinar. Thank you all for joining us today. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentation via the Q&A feature or in the chat box on your webinar console. Just a friendly reminder to please be respectful when communicating in the chat and asking questions, and note that only questions or comments pertaining to the presentation will be addressed. This entire webinar is being recorded and will be available on the AIRP website, which I will put in the chat. You may also view presenter slides to follow the presentation on our Google Drive archive. That will also be in the chat. There will be a short evaluation survey at the close of the webinar. We invite you to provide feedback on this webinar and to also provide suggestions for future webinars. In the interest of time, let's get started. Next, Jessica, do you mind go ahead? You can start sharing and I will introduce. Great. So today we present the National Autism Indicators Report, the health and the COVID-19 pandemic findings, implications, and future directions. Next slide, please. We want to first acknowledge the Health Resources and Services Administration as the funding source for the AIRP. Next slide, please. It is my honor to introduce our presenter for today, Jessica Rast. Jessica is a research scientist at the A.J. Drexel Autism Institute of Drexel University. She works in the Policy and Analytics Center, examining questions about the lives, experiences, and services of autistic people. In her role, she catalogs and analyzes existing national data sources to present a national picture of experiences across life domains and the lifespan. Rooted in a life course approach to study, much of her work focuses on transition periods. She is particularly interested in health, healthcare, and models of health service provision. Please join me in welcoming Jessica Rast. And I would like to acknowledge her co-presenter, Caitlin Coffer-Miller, who could also not be here, but helped create these slides and presentation. Thank you.
Thank you. And thank you everybody for joining today. Like Bree said, I'm Jessica Rast, and my colleague, Dr. Caitlin Coffer-Miller, could not be here today, but certainly very involved in this work and in creating this presentation. So today we're going to talk about the National Autism Indicators Report on COVID, which was already presented earlier. So a few of the objectives of this particular report were to catalog healthcare during the COVID pandemic. That was really our main goal, and that was what we aim to do. And we have a few ways we looked at that, so I'll fill you in on those as we go along. Largely, we looked at changes in care provision over the beginning of the COVID pandemic. We examined that a few ways, including primary care and emergency care and hospitalization. And then we also looked at COVID treatments, so specific care for COVID. We looked at the use of in-person and telehealth services, because we know that the service environment changed a lot over this time. So we were interested to see exactly how that changed for autistic people. And then we also made sure to examine by different key characteristics. So were the experiences that people were having during this time different based on age, race and ethnicity, diagnosis, insurance status, other things like that we'll go over as well. So it's 2023, the pandemic started more than 3 years ago, and it's technically over, although we know that COVID's still around and probably will be for a while. But given that, what's the so what of doing this report? So we really were aiming to understand how the long-term impact of COVID and service disruptions impacted people, their health, their connection to their needed services. So we're able to examine that here. We also aim to understand how we might improve healthcare and the public health infrastructure for future times of crises. We know this was a crazy time. This was a 1 in a 100-year kind of interruption, but these things may become more common. We also know that improving the infrastructure for care can improve care for people in normal times. So that's part of the goal as well. There was really a key component here with the introduction of telehealth, or the expansion of telehealth. It's certainly been around for a while, but we really saw some really quick changes of healthcare technology. So we wanted to understand how those were implemented and how effective those were. And then finally, examine some of the policies that impacted the care that people were able to receive and how they were able to access that, and how this may have improved or hindered outcomes. So for this report, we were, with those goals in mind, we aggregated a few data sources to try to answer this across the life course or across all ages of people. So the first data source we have here is the National Survey of Children's Health. This is a survey that's of a national representative sample of all children in the US. And it is a survey given to parents and caregivers and basically focuses on health and well-being. It's really nice because it's repeated yearly, and it has been for a while. So we're able to look at changes over time using this sample. The next two are two national sources of all-payer hospital information. So we've got emergency department and inpatient hospitalizations. So we're able to look at the use of those sort of crisis care situations during this time. Both of these are collected by the Healthcare Cost and Utilization Project at the Agency for Healthcare Research and Quality. And they cover a very large national picture. The national inpatient sample covers more than 46 states, and the emergency department sample is more than 36 states. And then finally, we looked at Kaiser Permanente Northern California patient medical records. So we worked with our colleagues at ARP over at Kaiser or KPNC to examine some of the health and service use in their specific population, which is in Northern California, people insured by Kaiser. We were able to look a little more detail in those patient records. So it's a great addition to what we're able to find from these national sources. So we know that there were a bunch of environmental changes during this time, and specifically I want to talk about some of the service changes that led us to look into this topic. So COVID mitigation efforts led to restrictions in healthcare services. People were not able to go receive services for certain things. They couldn't go to the hospital for routine care. There were just changes in what people were able to access. And then there was also the, more social pressure to not receive care because you might have been afraid of going out and contracting COVID. We know that autistic people had challenges in accessing healthcare in general, but also specifically during this time. And that's what we aim to look further into with this report. And then in general, there were also increases in crisis care utilization, so hospital emergency department, due to disruption in services. So if somebody was not receiving the primary care or the outpatient care that they might have needed to keep a health condition under check, it might have resulted in escalation to a crisis. So I'm going to talk about four main things to overview our findings. And the first one here is insurance and policy changes. So in general, in the US, we know that there was an increased reliance on public safety net during this time. There were changes in policies that led to more people qualifying for public safety nets, including one-time payments or monthly payments, and then also Medicaid and public health insurance. The Family First Coronavirus Response Act was one of those policy changes that ensured continuous Medicaid coverage. And then there were also expansions in the eligibility requirements where more people could qualify for Medicaid. And overall, we have seen in general population an increase in Medicaid and CHIP enrollment between the beginning of the pandemic. So April 2020, which is right around when mitigation efforts first started in the US, to December 2021. And then we did see a corresponding decrease in uninsured rates, which is great. So more people were qualifying for and using Medicaid, so we saw fewer uninsured people. When we look specifically at autistic children, from the National Survey of Children's Health is one of the sources we were able to look at this. We saw that the majority of autistic children had public health insurance, so Medicaid or CHIP. But we did not see a real decrease in public insurance coverage, increase in public insurance coverage over this time period where like they did in the general population. It was pretty consistent. But we did notice differences in insurance coverage by race and ethnicity. So I'll talk about those a little bit more detail. So in this graph, the leftmost panel is showing private insurance coverage. The middle is public, and then the right panel is uninsured. So we're looking at change from 2019 on the left side of each graph to 2021. And then the blue line is autistic children. And then the gray line is children with special healthcare needs that do not have autism. So I'll start with the middle because I was talking about public insurance. So we see 55% of children with autism had public insurance in 2019, as did 58% in 2021. So we didn't see too much of a change here, but the majority of children are being served under public insurance. Now we're looking at public insurance or insurance status in 2021 only by race and ethnicity. And the thing I really want to point out here is that Hispanic autistic children and Black autistic children are by far the most likely to have public insurance. So 2/3 of Hispanic children and almost 80% of Black children, autistic children, had public insurance in 2021. There were a lot of changes to public health insurance during COVID. So the ability of those policy changes to impact Hispanic and Black children was really increased because we do see such high coverage of these children during this time. So that's a really important intervention point for receiving access or receiving care and getting better access to care. So the next topic, so we just talked about insurance coverage. The next topic is direct COVID care. So when people had COVID, the care they received. And we have a little bit of info on this, mostly looking at hospitalization and emergency department use. So some of our main findings were that older autistic adults were at the highest risk for COVID-19 hospitalization. We did see increases in emergency department visits for older adults. And by far the majority of COVID hospitalizations and emergency department visits were covered by public insurance. So either Medicaid or Medicare, depending on age here. So we'll start with emergency department visits. I'll give you just a little more detail about the overview I just gave you. So COVID-19 visits to the emergency department were the most common in older autistic adults. And I'll show you what my age groups are on the next slide. Rates of emergency visits were similar for younger autistic adults and younger non-autistic adults. So the rates were very similar for autism versus not autism. And then we did see surges in visits that correlated with some COVID-19 policy changes. Okay, so you'll see a few of these graphs, so I'll just orient you to it really quick. So we're looking at the percentage of emergency department visits in autistic people that were for COVID. We're looking at autism on the top and then people who are not autistic on the bottom. And then the time here is months. So we go January through December of 2020. I've added a few arrows to orient us to 3 years ago to remember what was happening then. We were seeing the first peaks in COVID in the US in March and April. And then we saw one of our second peaks in the winter, so November, December. So what we see in these graphs that I really want to point out is this high bump, between 10 and 15% here for autistic older adults, which in this case is adults ages 45 plus. I apologize to anybody who is 45 and does not want to be called an older adult. This was really done for sample size. It's not a statement on age and old. So the older adults here, we see this peak that is much higher than the corresponding peak for the older adults who are not autistic. And then we see the same thing at the end of the year, this higher peak for older adults. And in general, emergency department visits for younger people were less. So we know that COVID was more severe in older people. I also mentioned that public insurance is really important for these hospital visits. I'll reiterate that this is an all-payer system. So this is a nationally representative sample of people who go to the emergency department. So we see a lot of public health insurance coverage. So in these older adults here, 81% were covered by Medicare, 13% by Medicaid. So almost everybody was covered by public insurance. Similar story here, we switched more Medicare coverage, but still a lot of public health insurance for middle-aged or younger adults and youth or children. So we just looked at emergency department, and I'm going to show you the same things for inpatient hospitalization. So when you get admitted to the hospital, and we actually saw very similar results as we saw with the emergency department. I would say the major difference is that hospitalizations were much less common in children than were ED visits, but we see the same patterns. So let's look at those. This is the same graph showing the same thing. So the percentage of inpatient admissions that were for COVID. We have these peaks again, so the surges in April and in the winter. And we see that the peak in April for autistic older adults is around 20% of admissions, which was double what it is for non-autistic adults, which is 10%. So hospital visits, admissions for COVID were higher in autistic people. We see in general lower admissions for children and young adults in both groups. This is almost the same map. I had to check that I didn't accidentally paste the wrong map because the coverage for insurance for inpatient visits is almost exactly the same as it was for emergency department visits. So we see a lot of use of public health insurance for COVID. All right, so the next thing that I want to talk about is other healthcare services. So we just looked at COVID care, but one of our main questions is how did the pandemic or the structural changes that occurred during the pandemic impact the use of and access to healthcare for people, for general healthcare? We know that access to healthcare was disrupted during this time for a variety of reasons. We have seen decreases in healthcare utilization for autistic people, and then an increase in virtual visits, which was a great way to try to get people in without exposing people to the COVID environment. So first I want to look at children. So this is the National Survey of Children's Health again. And in general, we noticed some small decreases in healthcare use in children from 2019 to 2021. And the biggest decreases were seen in emergency care, so going to the emergency department. We did notice some differences in care in 2021 by race and ethnicity, and I want to point those out too as we go. So this is looking at 4 types of services from the National Survey of Children's Health. The top left is dental, and then we've got emergency department visits, healthcare visits, and preventive health services. We're looking at 2019 versus 2021 again, and then the blue bar again is for autistic children. We do see some small decreases in dental health. So, for example, autistic children 86% had a dental health visit in 2019, and 81% did in 2021. But if we go to the next graph on the right, we see these 10% decrease in emergency visits, smaller but still decrease in health visits and in preventive health services. So we do see similar patterns for autistic versus non-autistic children. And in general, very similar usage of these services. Here we're looking again by race and ethnicity. So this is similar to that graph I showed a few slides back. These are the same 4 services that we looked at on the previous slide. So healthcare, dental care. I'm sorry, I just realized these are not in order. That's very annoying. Preventive health and emergency department visits. And we do see some differences here. So in general, there's a bit of a descending, this is in reverse alphabetical order. And we see a bit of a descending receipt of all of these services in alphabetical order, which is just happened to be the way it is. So In general, Asian children, autistic children were having the lowest receipt of any of these services, and white children generally had the highest receipt. So we looked at, just previously, we looked at actual use of care of services, and now we're looking at parent report of some things that might help access services. So specifically, we're looking at referrals and care coordination. And in general, we did see decreases in receipt of care coordination from 2019 to 2021. And we also saw increased parent report of difficulty in receiving care coordination during this time. So similar graph set up here. So we've got difficulty getting needed referrals in the top left. So we do see a slight increase in this proportion from 2019 to 2021. So more parents or caregivers reporting that in 2021. And we also see that the difficulty is generally higher in autistic children than it is in other children with special healthcare needs. If we go to the right, we see need of referral. So there's actually a very small decrease, generally, the same level of need for a referral over this time period. And then one down is receipt of care coordination, which we see decreased over the time period as well. The bottom left here is the report from a parent that the child needed healthcare but did not receive it. And we actually see basically no change in children with special healthcare needs and maybe a very small decrease in autistic children. I think this is a little contradictory to maybe some of these findings. Increased difficulty getting referrals would suggest that there may be healthcare that's needed, that's not received. But in general, I'd say that the unmet need is somewhat low report here. So we did see an in general decrease in these access metrics. So now we're going to look at changes in emergency department use. So this is a data source we looked at before for the COVID. We did see sharp decreases in emergency department use over 2020. And only did we see a return in ED visits in the older autistic adults. The use remained low in children and younger adults. So these are the same graphs, but now we're looking at counts. But basically, I think the most important part is just the pattern that you see on these graphs. So we've got autism on the top. And again, we've got these first COVID peaks in 2020. In March and then especially into April, we see this very sharp decrease in ED use, emergency department use for all people, autistic and non-autistic. And then this top line here is children. And so we don't see a increase to pre-pandemic ED use here. We see lowered use of emergency department throughout the rest of 2020. That's generally true as well for young adults, but a bit more of an increase back to pre-pandemic levels. So it's definitely the sharpest for children. And this is a largely similar pattern to non-autistic people, although the increase to pre-pandemic levels is maybe a bit higher here. And just a note, in case you're looking at this graph and wondering, these are counts, and the counts of autistic older adults are quite small in comparison to the general population. So that's why this line is at the bottom of the graph instead of the top. So now we can look at the same thing, but in inpatient admissions. So we see a very similar story again. We see these sharp decreases in use of admission to the hospital for autistic and non-autistic people during April. We do see an increase back to pre-pandemic levels in adults, I would say, but not in children. So return to care for inpatient hospitalizations was maybe a little bit quicker than for the emergency room. And that's the same pattern you see here in children that are not autistic and younger adults. So I think the emergency department use of emergency department was impacted a little more than was the inpatient admissions. All right, so now we're going to look at service changes from the Kaiser Permanente people. So we're looking at autistic adults here, not children. In general, we were able to look at primary care and telehealth in Kaiser, which we have not yet been able to do. So this is a great addition to this report. And we saw increases in telehealth, which makes sense, and decreases in in-person visits. And we also saw some differences by age, which I'll talk about as well. So here we're looking at similar graph, but a little bit of a longer period. So starting in February 2019 to February 2021. And we're looking at counts of, let's start with this blue line. So this is counts of in-person primary care visits. The first known case of COVID is marked here. And then I've added this April arrow again for our first real surge. And we see a very sharp decline of primary care visits in this population. And then a small increase, but nowhere near back to pre-pandemic levels. And then we have a corresponding telehealth line, which is this yellow line. We see somewhat steady but low use pre-pandemic. And then we see a pretty quick increase, which is good. We saw an increase almost immediately when people needed services to make up for the lack of in-person services. And a pretty steady use after implementation in the beginning of the pandemic. What this pinky purpley line is the combination of the two. So we have in-person plus telehealth visits here, but we do see that in general, fewer people were accessing primary care, either from in-person or telehealth at the beginning of the pandemic. But there was a bit of a bounce back, although not quite to pre-pandemic levels. So overall, we did see a decrease in the access of primary care over this time, even with the addition of telehealth. So it did a great job in some regards, picking up the slack, but maybe not all the slack. This graph, we're looking at primary care visits. So any visit, which corresponds to that purple line we're just looking at, and then specifically telehealth. And this is by age group. So the oldest people are on the top, and then we go down to the youngest adults on the bottom. The lighter teal line on the right of the primary care visits is 2019, and then the darker line here on the left for any primary care visit is the 2021. So we see a decrease in any primary care visit for every age group, but we see the biggest decreases for the younger people. So younger people were less likely to have care after the pandemic started than were older people. We saw big upticks, the biggest upticks in telehealth for the older age groups. So that maybe makes up part of the difference for the primary care visits we see in older adults, which is great because older adults often need more healthcare intervention than younger adults. So this is a promising finding. And then we were also able to look by race and ethnicity in the Kaiser data. So we saw decreases in primary care visits from 2019 to 2021, were the biggest in Black adults, in KPNC, and Asian adults. So pre-pandemic levels were largely similar. And then we saw these biggest decreases down here, and only 50% of Asian adults, autistic adults, had primary care visit of any kind in 2021. All right, so the next type of healthcare service that I want to talk about is mental health. We know that the COVID pandemic had a huge impact on mental health of the US population. So it's important to understand how the services might have picked up the need for more mental health care during this time, or didn't pick up the need. We also know that mental health service use is common among autistic adults, more so than, or not just adults, individuals, children and adults. More so than peers at times. So it's an important consideration for autistic people. So we'll start again with children. So we looked at mental health care in autistic children from the National Survey of Children's Health. We did see small decreases in the rate of mental health care and corresponding increases in the unmet need for autistic children. And then again, we did see differences in the receipt of mental health care by race and ethnicity, and also insurance status, which is one that I want to talk about as well, because that's got some important policy implications. And as we've seen so far in this presentation, there's a lot of public health insurance considerations during the pandemic, because that's where a lot of our interventions to increase care and increase support to people during this time came from. So we're going to start by looking at differences by race and ethnicity in the use of mental health care. So that's the top one here. So whether or not the child saw a mental health provider, and then unmet need, which is the bottom graph. So I highlighted a few things here I want to mention. So Black autistic children were the least likely to see a mental health provider than any children of any other race or ethnicity, which have pretty equal rates. So we've got low use in Black children. And then when we look at unmet need, we have the highest unmet need reported for white autistic children and children of another or multiple races that are non-Hispanic. So we do see, somewhat high rates of unmet need and high rates of care, but definitely differences here. So this is the same two questions. So did we see a mental health provider is on the top, and then the bottom is unmet need for mental health care. There are big differences by insurance status. So this first blue box on the top left, 47% of autistic children that had public insurance, so Medicaid or CHIP, saw a mental health provider in 2021. And this is compared to 21% of children who had private insurance. So that's a pretty big difference, more than double. And then when we look down here at unmet need, we see that the unmet need for children with public insurance is very low, it's 1%. And then for children with private insurance, it's 11%, so quite a bit higher. So children with public insurance seem to be having an easier time accessing needed mental health care than children with private insurance. So, there's a lot of differences in the care that's covered on private versus public insurance and the type of care that's reimbursed or maybe not paid for. So a lot of considerations there when we consider the high need for mental health care in this population. So we looked just now at the child responses from the National Survey of Children's Health, and now we're going to look back at the hospital data. So we saw that when we consider ED visits, emergency department visits for mental health concerns, there really wasn't much change in that across the year, across 2020. But in general, those are visits to the emergency department for mental health conditions is the most common in young autistic adults compared to any of the other age groups. So this graph is showing in autistic people in those three age groups we've been looking at, what percentage of all emergency department visits were for a mental health condition. So in the younger autistic adults, which is this top line, this blue line, we see that between 25 and 30% of visits were for a mental health condition across the whole year. So this is all months of 2020. It's slightly lower for children, so maybe 15 to 20%, and then lower still for older autistic adults, where there's other health conditions that lend them to the emergency department. But in general, we see a constant trend across time. And then if we look at the same thing, so instead of emergency departments, if we move our attention again to inpatient admissions, we see very similar things. So hospital admissions for mental health conditions are common in autistic children and adults, especially the younger adults. The one difference here from the previous, where we looked at emergency department, was that there actually was a relatively large decrease in hospitalization for mental health conditions for older autistic adults. So the proportion of hospitalizations for mental health conditions decreased by 10% in older autistic adults from April 2019 to April 2020. And this might be a consequence of that very vast increase in COVID admissions in older autistic adults compared to other people. but we did not see these decreases in children or younger adults. This should look similar to the last graph we looked at for emergency department use, except the rates are quite a bit higher. So between, I think, 43 and 47% of admissions for younger autistic adults were for mental health conditions throughout 2020. So it's largely consistent. This is for children. So we see, 27 to 35% of admissions, but we do see this bit of a spike in April and during the beginning of the pandemic. And then this lower rates for older autistic adults and corresponding decline here. So those are largely the results that I wanted to cover. So those are the main domains that we looked at. And I want to talk about a few research recommendations now, and then I'll talk about some potential policy recommendations in a minute as well. So one of the things that we saw was this increased need for and consistent need for mental health care, and potentially increased unmet need for mental health care during this time. So we are thinking it's important to do long-term mental health assessment. So what were the long-term impacts of this time period on people's mental health and the trajectories of mental health? We know that the pandemic's over, but this was a long time of impact, and it was very severe in a lot of cases. So understanding how that might impact people's need for care in the future is going to be really important. Another research recommendation that came out of these findings is telehealth. So we did see this increased need or in use of telehealth, but in other research, we have seen that telehealth may or may not be of standard or quality that is effective for care. So we really need to understand the effectiveness and the impact of telehealth on general healthcare and specifically mental health care for this population. There's also a lot of considerations with accessibility. So telehealth may be tailored to better provide for the accessibility needs of somebody, anybody. We all have accessibility needs. So we need to understand how we can do better in providing telehealth services that are more accessible, more high quality, and accessible not only, I'll talk about that in the next slide, accessible in several ways. So another, I think one of my final research recommendation is to examine some of these disparities in mental health care that popped up. So we did see differences in care and an unmet need by race and ethnicity. And so understanding what's driving these differences and how we can improve care for people in a tailored way. We have people that have mental health needs, so we need to improve care, but it's also important to understand what may be driving the differences in mental health conditions as well, to try to understand the mechanisms from the very beginning. Another thing that we uncovered was this difference in use and accessibility by insurance status. So it's important to understand what is public health insurance seem to be doing correctly in these cases that's allowing better access to mental health for autistic children. We should also investigate this in adults. Unfortunately, the data I had only was looking at children because of some data limitations, which we always run up against. But if we can understand the policy places where these improvements in care are being made and improvements in accessibility, we can begin to implement those or require implementation of those in public insurances, private insurance as well, to improve care for everybody. Okay, so on to some policy recommendations as well. So one of the key considerations here is accessibility. Some of the accessibility things that we're talking about are catering to diverse needs like sensory friendly environments. These are both considerations in person and in telehealth platforms. So there's considerations across all care settings. There may be recommendations around minimizing stimuli, crowded waiting areas, and then the provision of accommodations that anyone might request. So this could be quiet spaces, this could be appointment times. And all of these recommendations are also tied to budgeting concerns or spending concerns. So this might require changes to reimbursement structures. And these are, I mean, it's money, so people never like to change it or to talk about it, but these are all doable things and things that have changed in the past. And if we can provide evidence to suggest that these are more increasingly necessary things, I certainly think this is a pullable lever. And then there's changes around communication strategies. So people have diverse communication preferences and styles. This might include visual aids, maybe written instructions, and it might include things like simplified language, which everyone can benefit from, and they should be doing more of anyway. So another one of our policy recommendations here is to support and really bolster the use of telehealth and virtual care. It really did pick up a key role during the beginning of the pandemic and provided care to people who could not access in-person care, which was a lot of people. We weren't allowed to go anywhere. So the continued support of telehealth and virtual care options in general is very important, and also in mental health services specifically. One of the ways that this comes into play is by easing portability restrictions, which was done during the beginning of the pandemic, meaning that providers were allowed to provide mental health care across state lines, which has historically not been allowed. But this allows people to access providers that might be a better fit for them, even though they don't come from their location. But if we're on the internet, our location seems less and less important. Another recommendation here is to expand the coverage to ensure equitable access to individuals in diverse geographic areas. This might have to do with portability restrictions. There's other implications here as well, as far as different types of telehealth and the catchment areas for patients. And it also provides opportunity for affordability and accessibility. So we have barriers like transportation. We know that mental health care is very expensive and may or may not be reimbursed by insurance providers. So there are potential things here that telehealth can really help support. And there's also those sensory considerations that we've talked about. They might be better in a virtual environment or less present. And so just to wrap it up here, we did see a lot of evidence of impact of the COVID-19 pandemic on autistic people. We saw a lot of, in our findings and in other findings, there's evidence of significant impact and challenges for people in all aspects of life. So we focused really on health here and healthcare, but this has been shown in other areas as well, including education and employment and overall well-being. We also know that autistic people may have increased vulnerability to severe COVID infections. So we saw higher rates of emergency department and inpatient hospitalization for older autistic adults compared to their peers who are non-autistic. This could be related to risk factors for severe COVID. We know that certain health conditions are risk factors, and those are more common in autistic people than in non-autistic people. Some of those are obesity, chronic lung disease, diabetes, and kidney disease. So all of these things may lead to a more severe case of COVID. And then we talked about the decreased access to care. We saw a decrease in a lot of preventive services, including dental and primary care visits. And we also saw decreases in emergency care, so emergency department and inpatient visits. We saw greater reductions in care in younger people, and maybe this is related to lower healthcare needs compared to older individuals who are not able to push back their healthcare visits if their health condition may be more severe. And we also saw differences by a lot of key characteristics, including race and ethnicity and insurance status. We saw that Black and Hispanic children in particular experienced the largest decreases in care when compared to white children. So this is an important place to intervene to make sure we're improving care for everybody across the board. So this is just a little plug for the Policy Impact Project, which is us. This is where I'm coming from. Our goal really is to make all of our research findings. I don't actually do this part. This is Caitlin's part. I do more of the research. Caitlin is the master at this part, but we try to take our research findings and make them into actionable and digestible information that can get into the hands of policymakers, advocates, decision makers, other people who can really use the data to make change, which is our ultimate goal for all of us trying to improve in this case healthcare. And I think Bree's coming back now.
I'm coming back. I'm here.
Okay.
That was amazing. Thank you so much. I also realized that I did not put the earlier links like in the actual chat, so I'm going to do that now. They went to the wrong group, and that's okay. And then we do have some time for questions and answers from the audience. I know we have a couple submitted, so I'll start there, and then we'll probably have some time for some others. So first, we have Jess, when you looked at mental health care receipt by race, did you understand the perceived need for these services?
That's a great question. So there are definitely differences in use and perceived need by race and ethnicity. We didn't look at that because we don't have a way to look at that. I suppose we're looking at perceived need because we asked the survey asked the parents or a caregiver if they felt they had unmet needs. So I guess technically it was that was perceived need. Yes, but there is a lot of intricacies around who pursues mental health care, who might think that that's not something that they or their child needs. And those differ based on a lot of things. And race and ethnicity could certainly be one of those things.
Absolutely, thank you. And the next question reads, how much did increased risk in COVID for older adults change in their choices for non-COVID problems, especially mental health?
Can you bring that back up so I can read it again?
Oh yeah, sorry.
That's okay.
How much did increased risk in COVID for adults change in their choices for non-COVID problems, especially mental health?
I see. Okay. Yes, I understand. I don't know. We are not really able to look at that, but I think that if I understand your question correctly, telehealth would be a key component here. So if their potential risk factors for severe COVID were high, they may be limited in the in-person care that they can receive. So if they need mental health care, but they only have in-person options, they might not be able to receive in-person health care, especially if they're worried that they might contract COVID. And I know that drove a lot of care decisions in the early pandemic, through the whole pandemic. It drove a lot of care decisions for people, but especially in the beginning. So I certainly think this is an interesting question that is something that we did not look into because we didn't have data for that, but is an important consideration because I do think it probably drove the care landscape a lot.
Got it. Thank you. And while others maybe think of a couple other questions, where do you see like next steps for COVID and this project going?
Yeah, it's a good question. I think that there's a lot of translation of these findings to driving how policy could change so we can improve healthcare in general. I think, this is an extenuating circumstance. We had this pandemic, we had all these changes in healthcare that happened so rapidly. But I do think a lot of these lessons can improve healthcare in general, normal times, whatever normal means. And I specifically am interested in a lot of these mental health care access problems. So I think considering how we can improve mental health care for autistic people and people in general, especially through the telehealth option. Because when you consider the availability of providers, especially providers who want or feel comfortable and confident in accepting autistic patients, you might have a limited pool. And so the use of telehealth, the release of the restrictions on portability or interstate provision of care might be one key way to provide better care, better mental health care for people.
Yeah, absolutely. It definitely is multifaceted, and time will tell, how everything all plays a role and it plays out. But thank you for that. I think just this other question is just kind of a general your visuals and how the graphics were created for your slide. It says, can you share what programs or packages were used to create these clear data visuals? Because they did look
thank you. I appreciate that. Hopefully that means you like them. I did not make them. One of our data analysts made them, Jonas. He made them in R. I do not know the name of the package he used, so but I can find out and I could send it maybe to you, Bree.
Okay.
I don't know if there's any follow-up, but he used R. So I know there's a lot of visualization you can do in R, and he particularly likes this. I believe he used the Magma color palette to be more accessible to people with vision limitations. So he put a lot of work into it.
Okay, great. That wasn't an honest question, but I'm also interested myself. So yeah, we'll add that maybe to the website at the bottom for folks that are interested in that. And with that said, the slide that's up now is about the feedback survey. So we want to give folks a chance to give some feedback. I will post that in the chat. And then also, if you could go to the next slide, please. Great. Give folks the opportunity to follow us on social media. And finally, next slide, please. I would like to invite you all to register and attend our next webinar in October on the 24th, presented by Priya Chandan and Keisha Rosenaw. And that registration is also in the chat. They're going to be talking about their disability curriculum that they're implementing within schools and stuff. So that is all. If there's no other questions, I thank you all for your time. Thank you so much, Jess Ross, and thank you, AUCD. Take care, everybody.
Thank you.